Bismillahirrahmanirrahim. Today we are going to start with the concept of decussation and bulbar and pseudobulbar palsy. So let's start with the concept of decussation. What is meant by that? Decussation: upper motor neuron cross below the medulla. Lesions above the decussation will lead to contralateral dysfunction, and lesion below the decussation will lead to ipsilateral dysfunction. So corticospinal tracts are the ones which are starting in the cortex, right? In the premotor, in the motor, and in the somatosensory cortices. These are the corticospinal tracts which bring the motor innervation from the brain all the way down to the spinal cord, where they activate the lower motor neurons, and then lower motor neurons go to the respective neuromuscular junctions to perform the action. So then, as you can see in this picture, that the fibers which are coming from here, they are going all the way down until they reach medulla, like all the way over here. Let me change the color so that you can see it more clearly. Just give me a second. Yes, so these fibers have started, these fibers began over here, and they started going down all the way till the medulla, after which they decussated onwards, and the point where which they decussate is just under the pyramids of the medulla. If I draw medulla over here, just give me a second. Yeah, if I draw the medulla oblongata over here, so it looks something like this. So this is a cross section of medulla oblongata. The central things are called as pyramids, and the peripheral things are called as olives. So just below the pyramids, we have the decussation of the corticospinal tract, like this and this. So that is the reason why we call them pyramidal tracts, or that is the reason we call them pyramidal tracts. Then what is meant by bulbar muscles, or bulbar? What is the meaning of the word bulbar? Bulbar muscles are supplied by the cranial nerves in the brainstem. Cranial nerve 5 supplies the jaw by the mandibular branch. Cranial nerve 7 supplies the face. 9 helps in swallowing, that is the glossopharyngeal nerve. 10 gives the innervation to the palate. 11 gives the innervation to the head, and 12 gives the innervation to the tongue. So these are the bulbar nerves which are going to supply the innervation to specific areas of head and neck. So why are they called bulbar? Because this area, if I draw the brainstem over here, and let me clear this. So if I draw the brainstem, like suppose this is the brain, and just below that we have the brainstem, will look something like this, and this, and there is cerebellum. So anything that is originating in the brainstem region, specifically, we include the whole brainstem, but to be very specific, the medulla is called as the bulb of the brain. So anything that is originating in the medulla oblongata or the brainstem, which includes the midbrain, pons, and medulla, that will be called as bulbar, and the nerves which are coming out of that brainstem will be supplying the bulbar muscle and stuff like that. Now let's talk about the bulbar versus pseudobulbar. So bulbar palsy means cranial nerve damage leads to lower motor neuron lesion. If the lesion is lower motor neuron type, it is called the bulbar palsy, and if the lesion is upper motor neuron type, it is called the pseudobulbar palsy. Okay, so the cranial nerve damage, direct damage to the cranial nerves, will lead to lower motor neuron sign, and that is called the bulbar palsy. Absent jaw reflex and gag reflex, and tongue will be flaccid and wasted. If I am talking about pseudobulbar palsy, so there will be corticobulbar tracts will be damaged, and upper motor neuron signs will be there, which means that there will be exaggerated jaw reflex or gag reflex, and tongue will be spastic. It will not be wasted. Now let's talk about the concept of bulbar and pseudobulbar. Suppose this is the brain. This is the brain, something like this, and then we have the brainstem that is associated with that, midbrain, pons, and medulla. So I am saying that cranial nerves are originating from the brainstem. So what cranial nerves are originating? Suppose I am talking about the cranial nerve 3, which comes straight out of here, and cranial nerve 4, which comes from the back of the brainstem. So so keep our focus on cranial nerve 3. If I am talking about this cranial nerve which is originating in the midbrain is being supplied by an upper motor neuron that is coming from the cortex. Right? If the lesion is in this nerve directly, that is called as a bulbar lesion, and the cranial nerve itself is directly affected. If the lesion is in the upper motor neuron, then this nerve will overfire, because that will give us upper motor neuron type of symptoms. Actually, the cranial nerve 3 is not a part of the bulbar system. So let's suppose this is cranial nerve 5. The cranial nerve, okay, so this is not in the midbrain, but you got the concept. It's okay. I'm sorry. My bad. It is not cranial nerve 3. It is cranial nerve 5. Suppose that I'm talking about cranial nerve 5 that is originating from the pons, and this pontine trigeminal nerve, it is cranial nerve 5, and it is supplied by this upper motor neuron. Now if this upper motor, if this nerve in itself is damaged, like if the trigeminal nerve is damaged, that will give us bulbar palsy. But if the damage is in the upper motor neuron that was supplying the trigeminal nerve, then that will give us pseudobulbar palsy. I hope you got the concept, and I'm sorry for using the name of the wrong nerve. Now let's move forward. Now we are going to talk about the cerebral perfusion. I will try to escalate my speed because we have been very slow in the first 3 sessions. So cerebral perfusion, the brain perfusion relies on the tight auto-regulation. Cerebral perfusion is primarily driven by the PCO2. PCO2 also modulates the perfusion in severe hypoxia. Cerebral perfusion relies on pressure gradient between the mean arterial pressure and the intracranial pressure. So very important thing that the carbon dioxide is the one that is going to dictate the cerebral perfusion, and we use this phenomena for a very specific clinical finding that is called as therapeutic hyperventilation. We'll talk about that just now, but let's talk about this concept. The cerebral perfusion, if I write the formula over here, okay, so they have written it. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So mean arterial pressure is the arterial pressure that is present throughout the body, minus intracranial pressure is the pressure which is present inside your skull, the pressure which is inside your cranium. So if the intracranial pressure is less than the mean arterial pressure, then definitely the blood will flow into the brain. But if the intracranial pressure is equal to or more than the mean arterial pressure, no blood flow will be occurring towards the brain, and that will lead to ischemia or ischemic stroke of the brain. Now let's talk about decreased blood pressure or increased intracranial pressure will increase the cerebral perfusion pressure. Cerebral perfusion pressure is the pressure that is required to push the blood into the brain. Therapeutic hyperventilation decrease the PCO2, that will lead to vasoconstriction. So remember that decreased level of PCO2 leads to vasoconstriction in whole body, while it causes vasodilation in the lungs, and hypoxia causes vasodilation in whole body while it causes vasoconstriction in the lungs. So decreased PCO2 will cause vasoconstriction in the brain, that will decrease the cerebral blood flow, that will decrease the intracranial pressure, and may be useful to treat acute cerebral edema, for example secondary to stroke, unresponsive to other interventions. Cerebral perfusion pressure is equal to mean arterial pressure minus the intracranial pressure. If the cerebral perfusion pressure is equal to 0, there is no cerebral perfusion that will lead to brain death. Hypoxemia increases the cerebral perfusion pressure only if the PO2 is less than 50 mm of mercury. Cerebral perfusion pressure is directly proportional to the PCO2 until the PCO2 is more than 90 mm of mercury. Okay, what happens after that? Cerebral perfusion pressure is directly proportional to the PCO2 until the PCO2 is more than 90 mm of mercury. Where is PCO2? The PCO2 is over here. So until the PCO2 reaches 90 mm of mercury, the curve rises. The curve is directly proportional to this. As the PCO2 is rising, the cerebral blood flow is also increasing until it reaches 90 mm of mercury, after which the curve flattens out and there is no further increase in the cerebral perfusion pressure with increasing the PaCO2. Then we have the effect of PaO2. You can see that we require a very low level of oxygen, that is all the way to 25 mm of mercury, to elicit a strong increase, to elicit a very significant increase in the cerebral perfusion pressure. Normally the PaO2 is equal to 98 mm of mercury, something on those lines, 100 or 98 mm of mercury. As you can see that up till 50 mm of mercury, like the oxygen partial pressure in the brain, in the body, has fallen all the way down to half of its original concentration where it should be. Even then there is a very slight increase in the cerebral perfusion pressure. But for the PCO2, normal concentration is 44, I guess 44. Yeah, normal concentration is near 44, and here you can see that near 44 the cerebral perfusion has already started increasing, and as we increase the PaCO2 up till 90 mm of mercury, it increases constantly, consistently, persistently until it reaches 90, after which the curve flattens out. So this is the concept of mean arterial pressure and cerebral perfusion pressure. Now let's move forward. So cerebral arteries and cortical distribution. Now this is a very important graph, and you must remember that this is if I draw a brain over here, if I draw a cut section of the brain like this, these are cerebral hemispheres. Anterior spinal artery moves in this central fissure and supplies the area of the brain which is present over here. The middle cerebral artery moves in the lateral sulcus and it supplies the lateral aspect of the brain, upward and downwards. So you must remember this thing. Now let's come back. Here you can see that this green area, the lateral aspect of the brain, is the territory of the middle cerebral artery that supplies the lateral surface, Anterior cerebral artery supplies the anteromedial surface. It is supplying the anterior surface as well as the medial surface. Then the posterior cerebral artery supplies the posterior and inferior surfaces. So the posterior surface, which is over here, the occipital lobe, and the inferior surface of the temporal lobe, all of that is being supplied by the posterior cerebral artery. Now there are some concepts which we already have discussed, and I want to repeat them. The very first thing is about homunculus. You know that the lateral aspect of the primary motor cortex, we have the face area, and then we have the hand area, and then we have other areas like that. So then we have these areas, and when we move dip into the middle aspect, here we have the foot area and the lower limb. Okay, so let's make our life easy. So this is the face, this is upper limb, and here we have the lower limb. If there is any infarct in the region of middle cerebral artery, the upper limb or the face area will be affected. If there is some infarct in the anterior cerebral artery distribution, the lower limb will be affected. And if the posterior cerebral artery is affected, the occipital lobe will be affected, and there will be cortical blindness. But the cortical blindness is a specific pattern that is called as the homonymous hemianopsia. Homonymous hemianopsia with macular sparing. Homonymous means same side of the visual field has gone. Like if we are affecting the right occipital lobe, so left half of the vision field in both eyes will be gone, right? But there will be sparing of the macular area in both eyes, because the macular area is being supplied by posterior cerebral artery as well as by middle cerebral artery. So that is why when there is some infarct in the posterior cerebral artery, the macula is spared. Now moving forward, what is watershed zone? It is a very important concept. The watershed area means in general in whole body, if this is some blood supply and its terminal branches, and there comes another blood supply with its terminal branches, so the area that is now between these two branches, the area that is between these two blood vessels, like this area, it is a watershed area because it is getting a bare minimum supply that is required for its metabolic activities. Now if there is, because of some reason, some XYZ reason, there was maybe there is hypoperfusion, maybe there is hypovolemia because of some sort of hemorrhage, or maybe there is some heart attack, so some sort of ischemia is over there. In those situations, the first area to be affected will be this watershed area, because already it has a decreased or minimum amount of blood to be supplied to this area. If there is some sort of damage to the blood supply and the blood supply is not reaching the whole body, the first areas to undergo infarction will be the watershed areas, because they already had a compromised blood supply. Now let's talk about this thing. So in brain, the sites of watershed areas are the cortical border zones. Now as you have seen in this picture, that there are areas, suppose this is the area of the middle cerebral artery and this is the anterior cerebral artery. The line of junction between these two areas will be a watershed area. Same is true over here, and same is true in these areas. So the between the anterior cerebral artery and middle cerebral artery, posterior cerebral and middle cerebral artery, blue area. So these areas can be seen as these wedge shaped areas in this picture. So these areas will be affected first whenever there is some kind of ischemia or some kind of hypovolemia and stuff like that. Typically appears as bilateral wedge shaped strips of the necrosis over the cerebral convexity, parallel and adjacent to the longitudinal cerebral fissures. Internal border zones between the superficial and deep vascular territories of the middle cerebral artery. So middle cerebral artery has superficial blood vessels and then deep blood vessels. So between the superficial and deep blood vessels, there are internal border zones which are depicted in this picture by this red area. So this red area is also watershed area, because suppose these are the superficial arteries and their terminal branches, and then we have the deep branches and their terminal branches. So the area between them is called as the watershed area. Now let's come back to the discussion. Damage by severe hypotension. Whenever there is some sort of hypotension, maybe there is septic shock and there is massive vasodilation and massive third spacing of the blood, of the plasma, that leads to hypotension, and that hypotension will be affecting watershed areas first. Symptoms of watershed area damage. If the internal border zone stroke, weakness of the shoulder and thighs will be seen, sparing of the face, hands and feet. There will be bilateral symptoms, and that will be called as a man in a barrel syndrome in the cases of internal border zone stroke. If the posterior cerebral artery and middle cerebral artery cortical area zone stroke, higher order visual dysfunction will be seen. So you must remember the man in the barrel. It is a very important diagnosis, that the face, hand and feet will be spared, but the shoulders and thighs will be weak. Then we have this thing. So this is the anterior cerebral artery territory, and this is the watershed area of the anterior cerebral artery and middle cerebral artery. There are the middle cerebral artery to posterior cerebral artery watershed area. Now this is the blood supply. So I guess there is a picture. Yes, there is a better picture. So we'll talk about this first. What is circle of Willis? This circle that is being formed is called as the circle of Willis. Now let's talk about this. Systems of anastomosis between the anterior and posterior blood supplies of the brain. So anterior, as you can see, up till here is the posterior blood supply of the brain, and above that we have the anterior blood supply of the brain. So the anastomosis between these two creates a circle that is called as the circle of Willis. Now let's talk about that. So here you can see that from the let's start from there. From the arch of aorta we have brachiocephalic artery, right? The brachiocephalic artery is divided into common carotid artery that gives rise to external carotid artery and internal carotid artery. This internal carotid artery, yes, okay, I'm sorry. So the arch of aorta is going to give rise to the brachiocephalic artery that will give rise to common carotid artery and then internal carotid artery. This internal carotid artery is responsible for forming the anterior circulation of the brain, right? The arch of aorta also gives rise to subclavian artery on both sides. This subclavian artery gives rise to vertebral artery, this blue one. This vertebral artery gives rise to posterior circulation of the brain. I will start with the posterior one. So now here you can see that these vertebral arteries on each side are coming from the subclavian arteries, right? So this vertebral artery, when it is coming upwards, gives rise to posterior inferior cerebellar artery and anterior inferior cerebellar artery. These are called as pica and ica, right? Two vertebral arteries anastomose together to give rise to anterior spinal artery. If I draw a spinal cord over here, something like this. There is a butterfly inside, and this and this. And this is the spinal cord, and there is a central fissure in the spinal cord. In this central fissure, we have an artery that is called as the anterior spinal artery, and there is a very specific. This is the anterior spinal artery that is formed due to the anastomosis of both the vertebral arteries. If there is some occlusion in the anterior spinal artery, there will be a very characteristic finding that the anterior 2/3 of the spinal cord will be dysfunctional. The posterior columns, which take the sensation of vibration and proprioception, that will be intact. Other than that, all the sensations and the motor functions of the anterior 2/3 of the spinal cord will be gone. Now let's come back to the circle of Willis. So we were talking about the anterior spinal artery, and then both the vertebral arteries fuse together to form the basilar artery. This basilar artery is now running over the pons. On the pons, they will give rise to pontine arteries and superior cerebellar artery. So we have cerebellar blood supply is coming from the pica, the ica, and superior cerebellar artery. Then the basilar artery terminates by dividing into two posterior cerebral arteries on each side. These posterior cerebral arteries supply the occipital lobe, and you may say the posterior and the inferior parts of the brain. Now let's talk about the internal carotid artery. As you know, the internal carotid artery comes by bifurcation of the common carotid artery into external carotid and internal carotid artery. I will talk about a branch of the external carotid artery that is very important in the CNS session. But the internal carotid artery that enters the brain and get itself divided into anterior cerebral artery that is going to move in the central sulcus, not the central sulcus, that is between the fissure between the two hemispheres, that will travel in the interhemispheric fissure. So that is the anterior cerebral artery. It will also get divided into the middle cerebral artery. So these are the two main branches, right? Anterior cerebral artery and the middle cerebral artery. Then it gives posterior communicating artery which connects the internal carotid artery directly to the posterior cerebral artery. We also have anterior communicating artery which causes the communication between the two anterior cerebral arteries, right? And there is a direct branch of internal carotid artery that is called as the ophthalmic artery. Other than that, we have the lenticulostriate artery, which is very important because any damage to the lenticulostriate artery can lead to the basal ganglia infarction, and the anterior choroidal artery, which is also going to give the blood supply to the basal ganglia. Now I was talking about a branch of the external carotid artery. Remember that the artery that we call the middle meningeal artery, so MMA, the middle meningeal artery. This middle meningeal artery is a branch of the external carotid artery, and it gets damaged whenever there is some direct injury to the pterion region, some direct injury to the lateral aspect of the skull, so that can lead to the extradural hemorrhage, extradural hematoma. We'll talk about that later in the discussion of the pathologies, but for right now, the only branch that is very important for you to remember in the CNS is the middle meningeal artery that is coming from the external carotid artery. Rest aside, all the branches are coming from either internal carotid artery or the vertebral artery that will make the circle of Willis. And how is that formed? We have already discussed. Now let's see this diagram. So there is the same concept. They have shown you that this is the subclavian artery. The subclavian artery is giving rise to the vertebral artery. Like this is the subclavian artery. If you follow this subclavian artery, like this is the subclavian artery. So this subclavian artery is given rise to this vertebral artery. Now this vertebral artery is going upward. Along with that, we have the common carotid artery, which has given the internal carotid artery that is also going upwards. Now you can see, Now you can see that this internal carotid artery is going to supply the anterior part of the brain, while this vertebral artery is going to supply the posterior part of the brain. So this is how it works. Now moving forward to this diagram. So sometimes you are given an angiogram like this in the Uworld, and they tell you like you have to identify which artery is which. So here you can see we have the vertebral artery, then the basilar artery. How do you know it is vertebral artery? Because if you see the origin, you can see this vertebral artery is fusing with this other vertebral artery this vertebral artery is fusing with this vertebral artery to give rise to a common basilar artery, right? So that is how we know that this is vertebral artery, this is basilar artery, and this tortuous artery is the internal carotid artery which is present anteriorly. This internal carotid artery is giving rise to the anterior cerebral artery which is moving anteriorly, and the middle cerebral artery which is moving laterally. Then we have the next thing. It is also a picture. Now you have to identify. So this artery is the basilar artery. Let me change the color. Okay. So this artery over here is the basilar artery. B and C, this B1 and this C1, these are the posterior cerebral arteries. Then we have the D, that is the superior cerebral artery. This D is the superior cerebral artery. This D is the superior cerebral artery. E is the parapontine perforating artery. No one is going to ask anything in this detail. And anterior inferior cerebellar artery, this may be asked. This is ICA. So you must remember the angiograms. Now let's move forward to the ventricular system. Now this is something that we have already discussed when we were talking about, I guess, when we were talking about the carry to malformation, something like that. So ventricular systems, they contain lateral ventricles which are connected by the foramina of Monro to the third ventricle. Then the third ventricle is connected by the cerebral aqueduct of Sylvius to the fourth ventricle, and this fourth ventricle is connected by the lateral foramina of Leschka, and central foramen of Magendie by the is communicating by these foramina to the subarachnoid space. Now let's read this text. They are saying that the lateral ventricles they are connected to the third ventricle via right and left interventricular foramina of Monro. The third ventricle is connected to the fourth ventricle via cerebral aqueduct of Sylvius, and the fourth ventricle is connected to the subarachnoid space via foramina of Leschka, which are laterally, and foramina of Magendie, which are medial. Then the next thing is this is a diagram from the Uworld, and here you can see this is the ventricular system. Now these are the these are the lateral horns, not lateral horns. These are the lateral ventricles. So these lateral ventricles have anterior horns of the lateral ventricle. There are central part of the lateral ventricle, then we have the posterior horns of the lateral ventricle and the inferior horns of the lateral ventricle. This is a very gruesome detail and you are not supposed to remember this thing, but remember that lateral ventricles have a lot of horns, right? Lateral ventricles are perforating the whole of the telencephalon and diencephalon. We have discussed about this thing previously, but remember that they are entering forebrain. The anterior horns are present in the forebrain. The central part is present in the parietal. The anterior horns are present in the frontal lobe. The central part is present in the parietal lobe. The posterior part is present in the occipital lobe, and the inferior horns are present in the temporal lobe. Okay, so this was an accessory detail. Now let's move forward to the concept that these lateral ventricles, if I could zoom it further. So these lateral ventricles are connected to the third ventricle by the interventricular foramina of Monro. These two lines which you can see, these are the interventricular foramina of Monro. Now this third ventricle is connected via the cerebral aqueduct of Sylvius to the fourth ventricle. This fourth ventricle has two lateral foramina which are called the foramina of Leschka, and one central foramen that is called the median foramen of Magendie, right? And by these foramina it is communicating with the subarachnoid space, and then it also drains the CSF into the central canal, right? So here you can see this is also a picture, and this is the outflow tract of the whole thing. So the CSF is primarily produced in the lateral ventricles in the choroid plexus. That CSF that is produced in the lateral ventricle moves to the third ventricle. From the third ventricle, it is moving via cerebral aqueduct of Sylvius into the fourth ventricle. from the fourth ventricle via lateral foramina of Leschka or the median foramen of Magendie, it is going to enter the subarachnoid space. In the subarachnoid space, this is going to enter the subarachnoid space, and from the arachnoid granulations, this thing is going to enter the sinuses. The main one is the sagittal sinus. This sagittal sinus will ultimately drain into the confluence of sinuses, and they will go all the way either into the cavernous sinus or into the pterygoid plexus of blood vessels, pterygoid sinus. Pterygopalatine, I don't know the name of that. I guess it is pterygopalatine sinus or something. Maybe it's named it, I'm not sure, but they drain into the cavernous sinus for sure, but we'll see that later on. And for right now, this is the ventricular system. Okay, cerebrospinal fluid, it is made by the ependymal cell. Ependymal cells are the glial cells of the choroid plexus. They travel to the subarachnoid space via foramina of Leschka and Magendie. They are reabsorbed by the arachnoid granulation, then drain into the dural venous sinuses. Okay, then we have hydrocephalus. When does this condition develop? Now, as the name indicates, hydro mean water and cephalus means in the brain. So, if there is excessive water, if excessive fluid starts accumulating into the brain, into the cranium, that is called as the hydrocephalus. Increased CSF volume lead to ventricular dilation with or without increase in the intracranial pressure. This is very important. There are certain situations in which, although the CSF volume is increasing, but that is not causing an increase in the intracranial pressure. For example, if we are going to talk about certain situations like what's the name of that? Normal pressure hydrocephalus. So, in normal pressure hydrocephalus, there is chronic accumulation of the CSF into the brain. When the chronicity comes into play, that will lead to the ventricular dilation to such an extent that there will be no increase in the intracranial pressure, although the CSF volume has been increasing. We'll see that later on. But for right now, you must remember that hydrocephalus is dividing into either communicating or non-communicating hydrocephalus. Non-communicating is where is non-communicating or non-communicating. So basically, hydrocephalus is either communicating hydrocephalus or non-communicating hydrocephalus. Communicating hydrocephalus, decreased CSF absorption by the arachnoid granulation. So what is meant by communicating? Communicating means that there is a wide communication between the ventricular system, this whole thing, like let me clear this, that there is a very good communication between this ventricular system and subarachnoid space that is present over here, like the subarachnoid space which is present over here and the ventricular system. If they are communicating with each other freely, then that is called as communicating hydrocephalus. Usually due to the arachnoid scarring and post-meningitis or subarachnoid intraventricular hemorrhage. So the problem is that the arachnoid granulation. What are arachnoid granulation? If suppose this is the arachnoid matter and this is the pia matter, and above both of these things we have this sagittal sinus in the dura, right? Sinuses are basically moving in the dural sleeves, and we have our fluid, cerebrospinal fluid in the subarachnoid space. So there are certain granulations, certain outpouchings which are connecting the subarachnoid space to these sagittal sinuses, and these are called as the arachnoid granulations. If there is some problem or obstruction with these arachnoid granulations and fluid cannot pass through them, so that will result in the hydrocephalus, communicating hydrocephalus. Now let's move forward to the presentation of the communicating hydrocephalus. That will be headache. Key sign will be papilledema. CT hallmark will be dilation of all the ventricles, lateral, third, fourth, all of them will be dilated, and they can cause herniation as well. We'll talk about the concept of herniation later on, but herniation can prove fatal. Normal pressure hydrocephalus. The pathophysiology is gradual decline in the resorptive capacity of the arachnoid villi. Okay, so what is meant by subarachnoid and intraventricular hemorrhage? Suppose, I'm sorry, if I could bring that back, no I can't. So let's draw that again. Suppose this is the subarachnoid space, and here we have the CSF. Also in the CSF we have the circle of Willis. I am just drawing one artery, but the whole circle of Willis is floating in the subarachnoid space, right? So if there is some hemorrhage in the subarachnoid space, suppose there is some perianeurysm or stuff like that, that has caused the bleeding to occur in the subarachnoid space. Now the blood cells are moving into the subarachnoid space. When these blood cells go and try to move from the arachnoid granulation into the sagittal sinus, they get trapped into the arachnoid villi, and when they are trapping over here, they will block the arachnoid villi, and ultimately they will be communicating hydrocephalus. Now the next point is normal pressure hydrocephalus. Pathophysiology is a gradual decline in the resorptive capacity of the arachnoid villi with slow accumulation of the cerebrospinal fluid is the root of the problem. Pressure remains normal in the normal pressure hydrocephalus because gradual ventricular distension accommodates the CSF increase. Now if the CSF increase is happening over the course of minutes or maybe hours or days, that is felt as headache and stuff like that. All the symptoms will be there, papilledema will be there, and the ventriculomegaly will be seen, because that is an acute increase in the CSF. Acute increase in the intracranial pressure will also be there. But if the time span for the increase in the cerebrospinal fluid is in the years, so the ventricles, suppose these are the ventricles, and you were filling them with fluid slowly, gradually, and when there is gradual increase in the cerebrospinal fluid, so there will be a slow increase in the ventricular size, and that slow increase in the ventricular size will accommodate that fluid, and that will not cause an increase in the pressure. Because what is pressure? If we could remember the formula of pressure, that is equal to force occupied in the unit area. If there is sudden increase in the force, for example, in acute increase in the cerebrospinal fluid production, or due to some reason acute increase in accumulation of the cerebrospinal fluid, that will lead to increased pressure, right? But if the force is not accumulating, if the force that is applied by the cerebrospinal fluid is not increasing acutely, but it is increasing gradually, and along with that the area is also increasing, because I am saying that suppose this is the ventricle and the fluid was accumulating. As the fluid was accumulating, the ventricular size was also increasing, the area on which this fluid could exert the force is also increasing. So ultimately there will be no net increase in the pressure, because the force and area are increasing proportional to each other, and if they are increasing in proportion to each other, there will be no net increase in the pressure. That is why we call it normal pressure hydrocephalus, right? So pressure remains normal in normal pressure hydrocephalus because gradual ventricular distension accommodates the CSF increase. Enlarged ventricles on imaging will be seen. Compression of the corona radiata will give us a triad, that is very important triad. There will be urinary incontinence, that is urge incontinence, gait apraxia, that is magnetic gait, and cognitive dysfunction, that is sometimes reversible. So the person will be wet, wobbly and wacky, and that is seen in the patients who are in the sixth or seventh decade of their life, because the normal pressure hydrocephalus takes time to occur. Then we have normal opening pressure on the lumbar puncture. CSF pressure elevates only episodically. It does not result in the increased subarachnoid space volume, and there is gradual ventricular distension. So in the normal pressure hydrocephalus, the opening pressure in the lumbar puncture will be normal. It affects the elderly and it is idiopathic. Suspected mechanism is the impaired absorption of CSF. So the arachnoid villi, they are not obstructed or they are not clogged. Due to some idiopathic reason, they start degenerating, and there is not they don't act as efficient reabsorbers of CSF and stuff like that. So their absorption capacity decreases over time, and that may result in the normal pressure hydrocephalus. Treatment is the ventriculoperitoneal shunt. So a shunt is placed between the ventricles of the brain and the peritoneal cavity of the abdomen. So that ventriculoperitoneal shunt may help us treat the normal pressure hydrocephalus. It drains the CSF into the abdomen, and then it is from the peritoneum, it is absorbed into general circulation, and then the whole cycle repeats. What is micturition reflex? It is regulated by the following centers. Firstly, sacral micturition center. The sacral micturition center is located in S2 to S4 level and responsible for the bladder contractions. Parasympathetic fibers travel from the S2 to S4 ventral white matter within the pelvic nerves and stimulate the cholinergic receptors in the bladder wall. Then second thing that regulates the micturition reflex are the pontine micturition center. They are located in the pontine reticular formation. It coordinates the relaxation of the external urethral sphincter in the bladder contraction during the voiding. So the sacral micturition reflex, which are basically the parasympathetic fibers along with the pontine micturition center that is helping to release the external urethral sphincter, they are assisting in the micturition. While the third center, that is the cerebral cortex, it inhibits the sacral micturition center. So if there is some problem with the cortical centers, there will be increased activity of the sacral and pontine micturition centers, and that will lead to urge incontinence, right? That is also called as the neurogenic bladder. Now moving forward to the non-communicating or obstructive hydrocephalus. So the obstruction is somewhere inside the ventricular system. Any of the ventricle is not communicating with the next ventricle, and the subarachnoid space and the ventricles are not communicating effectively. That is why it is called as non-communicating hydrocephalus. So ventricles cannot communicate with each other, and ventricles cannot communicate with the subarachnoid space as well. So non-communicating hydrocephalus, structural blockage of the CSF flow within ventricles, often congenital. It has many etiologies. Maybe aqueductal stenosis, Chiari malformations. Okay, yes, we have seen that in the Chiari malformation, specifically Chiari 2 malformation, we have hydrocephalus and non-communicating hydrocephalus. Then Dandy-Walker malformation. Yes, the Dandy-Walker malformation is the one in which we have the degeneration of the cerebellar vermis and the fourth ventricle enlarges. Then the colloid cyst blocking the foramen of Monro, as you can see. Okay, no. Colloid cyst in the foramen of Monro. Colloid cyst, suppose there is a lateral ventricle over here and this is another lateral ventricle over here, and they are communicating with the foramen of Monro to the third ventricle. So if there is some obstruction over here in this thing, there is a colloid cyst that develops in the roof of the third ventricle, and that can block the foramen of Monro. So this lateral ventricle cannot communicate with the third ventricle, and this starts enlarging, and this is going to result in the non-communicating or obstructive hydrocephalus. Then we have a tumor, as you can see in this picture. So this tumor can also result in the non-communicating hydrocephalus, because it will be obstructing some of the region, like it may be obstructing the foramen of Monro, or maybe it is obstructing the cerebral aqueduct of Sylvius, or start anything. So if the tumor is obstructing the ventricular system, that will also result in the non-communicating or obstructive hydrocephalus. Then let's talk about the aqueductal stenosis, blocked drainage of third and fourth ventricle, congenital narrowing. It is excellent, and that if it is excellent, so definitely it is seen in the boys. Inflammation due to intrauterine infection, for example, rubella, cytomegalovirus, toxoplasmosis, or syphilis. Presentation is the enlarging head circumference. Hydrocephalus mimics. It is also called as ex vaccio. I'm sorry. Hydrocephalus mimics mean that the problem is not the excessive production of the CSF. Neither the problem is impaired drainage. Hydrocephalus is not there in, as a matter of fact, in the situations which we are going to study now. There is no hydrocephalus, but it appears to be hydrocephalus when we do the CT imaging. That is why we call it hydrocephalus mimics, that it looks like hydrocephalus, but in fact it is not hydrocephalus. So the first condition, which is hydrocephalus mimics, is the ex vaccio ventriculomegaly. Appearance of increased CSF on the imaging, as you can see in this picture. You can see that the ventricles are dilated very much, but is actually due to the decreased brain tissue. So here you can see that although the ventricles are dilated, they are dilated to a larger extent, but the brain substance is also decreased. As you can see, the sulci which are present over here, like these are the sulci, they have widened, and the gyri, they have shrunken. Like the sulci and gyri, if I draw the brain like this, so this indentation is called as sulcus, and this solid substance is called as the gyrus. So in our picture, the sulci have widened, the sulcus has widened, and the gyrus has shrunken. So this is giving us a picture of brain atrophy. So ex vaccio ventriculomegaly is the appearance of increased CSF in the brain, but is actually due to the decreased brain tissue and the neuronal atrophy. For example, in the Alzheimer's disease, advanced HIV, Pick's disease, or Huntington disease. Intracranial pressure will be normal in this thing, and the normal pressure hydrocephalus triad, that is magnetic gait, and the urge incontinence, and the confusion and stuff like that, that will not be seen. The only thing that will be seen will be enlarged ventricles with a normal pressure. The intracranial pressure will not be increased. The next thing that you need to know is the diagnosis. How do we diagnose the hydrocephalus ex vaccio? It is increased size in the ventricles in proportion to the increased size of the increase in the size of ventricles is in proportion to the increase in size of the sulci. The next thing is idiopathic intracranial hypertension. It is also known as pseudotumor cerebri. Even in this situation, there is no excessive production of CSF, but due to some reason, there is increased intracranial hypertension. Increased intracranial pressure with no apparent cause on imaging. On imaging, the ventricles are of normal size and everything is normal, but the intracranial pressure is increased because of some reason. That is why it is called as idiopathic intracranial hypertension. For example, hydrocephalus, obstruction of CSF outflow, nothing is there. Even then, there is increase in the intracranial pressure. The risk factors include the female gender, tetracycline, obesity, vitamin A excess. This is very, very high yield point, that vitamin A excess can cause pseudotumor cerebri. Then danazole, that is female, so the mnemonic is female toad. So female, tetracycline, obesity, and vitamin A and danazole is the drug. So these things can cause pseudotumor cerebri. Symptoms include intractable, disabling headache, so there will be very severe headache, worse with lying flat and improves with standing. There will be pulsatile tinnitus, rushing water or wind sounds, transmission of the vascular pulsations, diplopia usually from the CN6 palsy will also be there. Physical examination will show impaired optic nerve exoplasmic flow that will lead to papilledema. The visual field testing shows enlarged blind spots and the peripheral constriction. Peripheral constriction means the field of vision, suppose this was a normal field of vision, this will be constricted all the way only to this thing, to this level. The visual field will be decreased, that is called as the peripheral constriction, and no change in the mental status will be there. Lumbar puncture will show an increase in the opening pressure. CSF pressure is more than 250 millimeters of mercury with normal analysis. So when we analyze the CSF, there will be nothing. The lab values will be within the normal ranges, but the opening pressure will be more than 250 millimeters of mercury. And when we do the lumbar puncture, that provides temporary relief of the headache as well. So the lumbar puncture has both diagnostic and therapeutic significance. Treatment of the pseudotumor cerebri is the weight loss, acetazolamide, invasive procedure for the refractory cases, for example, the CSF shunt placement, optic nerve sheath fenestration surgery for the visual loss. The next point is about the dural venous sinuses. So the dural venous sinuses, they are very important to know. So dural venous sinuses are the large venous channels. They travel through the dura. They drain the blood from the cerebral veins. They receive the CSF from the arachnoid granulation superior sagittal sinus, as we have discussed previously that the arachnoid granulation drain the cerebrospinal fluid into the dural sinuses via the arachnoid granulation drain the CSF from the subarachnoid space into the dural sinuses. They empty into internal jugular vein. Okay, I'm sorry, I was wrong. They do not drain in the cavernous sinus. Cavernous sinus is also a dural venous sinus. All of them together drain into the internal jugular vein. The venous sinus thrombosis. The venous sinus thrombosis presents with the signs and symptoms of increased intracranial pressure, for example, headaches, seizures, focal neurological deficits, may lead to venous hemorrhage. It is associated with a hypercoagulable state, for example, the pregnancy and the oral contraceptive pill use, factor 5 Leiden and stuff like that. We'll talk about these conditions like factor 5 Leiden in the hematology oncology sessions. But remember that all of these situations are hypercoagulable states, and when there is hypercoagulability, the chances of hypercoagulability are there. They may cause thrombosis in these venous sinuses, and that may lead to venous hemorrhage as well. So here you can see that these are the sinuses. So the biggest sinus is the superior sagittal sinus, main location for the CSF returned by the arachnoid granulation. Then there is an inferior sagittal sinus. Then another thing is the great cerebral vein of Galen, which is draining the parenchyma of the brain. The straight sinus is connecting the inferior sagittal sinus and the great cerebral vein of Galen to the sagittal sinus, superior sagittal sinus. Then there is a transverse sinus, occipital sinus. All of them are joined together at the confluence of sinuses. Then this confluence of sinuses will go to the sigmoid sinus, which will drain into the internal jugular vein after passing through the jugular foramen. There are three nerves which also pass through the jugular foramen, that is cranial nerve 9, 10 and 11. That is glossopharyngeal nerve, vagus nerve and the accessory spinal nerve. All of them are also leaving the jugular foramen, and if there is some obstruction of the jugular foramen, that will lead to Wernet syndrome. Vernet. So that Wernet syndrome will occur if there is some obstruction in the jugular foramen. Then we have this cavernous sinus. Cavernous sinus is also draining ultimately into the inferior jugular vein. Then there is sphenoparietal sinus and superior ophthalmic sinus and stuff like that. And this is an angiogram of the sagittal sinuses. The next point is about the cavernous sinus. It is very, very important. So here you can see the cavernous sinus. That cavernous sinus contains a lot of structures. The most important structure is the internal carotid artery. This blue thing is the cavernous sinus, this thing and this thing, that is present on both sides of the pituitary, on both sides of the sala tertiary, got to be specific. So this contains cranial nerve 3, So this is containing the cranial nerve 3, the cranial nerve 4, 5, 1 and 5, 2. So cranial nerve 3 is the oculomotor nerve, the cranial nerve 4 is the trochlear nerve, ophthalmic nerve, there is a CN51, first division of the trigeminal nerve, and maxillary nerve, there is a second division of the trigeminal nerve. And then we have the abducens nerve that travels into the cavernous sinus substance along with the carotid, along with the internal carotid artery. Then we have the sphenoid sinus. Okay. After that, you can see that there is anterior cerebral artery, internal carotid artery, sphenoid, subarachnoid spaces over there, and a lot of that things like pyometer, arachnoid matter, dura matter. But the important thing is that you can see that the cavernous sinus is present in the dural sleeve, which means it is a dural venous sinus. Now let's move forward. The collection of venous sinus on either side of the pituitary is called as the cavernous sinus. Bilateral between the temporal and sphenoid bones, they collect the blood from eye and cortex. They drain into the internal jugular veins. Structures which are passing through the cavernous sinus, there are many nerves like cranial nerve 3, 4, 5, 1, 5, 2 and 6. Sympathetic fibers all traveling to the orbit. Also portion of the internal carotid artery is present in the cavernous sinus. What is cavernous sinus syndrome? Causes complication of the compression by the tumor, for example the pituitary tumor, thrombus and fistula. Infections of the face, nose, orbit, specifically the dangerous area of the face. If I draw the face over here, Like suppose these are the eyes and this is the nose. So this area is the dangerous area of face that also includes the upper lip. So it includes upper lip. Oh, I'm sorry for that, but it includes the upper lip as well. So this is the dangerous area of the face. Any infection from this site can go back to the cavernous sinus and lead to the cavernous sinus syndrome. Then nose, orbits, tonsils, and soft palate can spread to the cavernous sinus, septic thrombosis through the valveless veins. And another thing that can happen is the carotid cavernous fistula. What happens is that if there is some damage to this carotid artery present over here, that will cause the rupture of blood directly into the venous channels. Internal carotid artery is because it is an artery, it is a high pressure system, and cavernous venous sinus is because it is a vein, so it is a low pressure system. If there is some damage to this artery, the blood from the high pressure arteries will enter directly into the low pressure venous system, and there will be a fistula formation that is called the caroticocavernous fistula, and it has a lot of hemodynamic complications which are associated with any other fistula along with cranial signs and symptoms. So symptoms are CN6 is most susceptible to injury because you can see that it is traveling into the cavernous sinus along with the internal carotid artery over here. So coming back, CN6 is most susceptible to injury, then there will be headache, swollen eyes, impairment of the ocular motor nerve, ophthalmoplegia, Horner syndrome, sensory loss of first and second division of the trigeminal nerve because both of these nerves also move into the wall of the cavernous sinus, lateral wall of the cavernous sinus. Now here you can see that these are the blood drainages coming to the cavernous sinus. The lacrimal vein drains into the superior ophthalmic vein that can go to the cavernous sinus. The nasofrontal vein and the anterior ethmoidal vein and the posterior ethmoidal vein, all of them drain into the inferior ophthalmic vein that can ultimately go to the cavernous sinus. Then we have the subcortical structures. They are very important structures. They are the basal ganglia, the thalamus, and stuff like that. So the structure which we are going to talk about right now are subcortical structures that lie between the cortex and the brain stem. They include thalamus, hypothalamus, limbic system, and basal ganglia. All of these things are called as subcortical structures. You should be able to identify these structures anatomically by imaging. So when we do the imaging, so this structure, like all of this structure, this and this, all three structures are called as thalamus. Because thalamus is a group of nuclei, there are multiple subsets of the nuclei which are present in the thalamus. We'll study about most of them in first aid. Then if we do a cut section like this, so the thalamus is present over here, like this is thalamus and this is thalamus. Okay, so these are axial sections and coronal sections. So in the coronal section, if we cut it like this, so this is thalamus, this area. And if we do the axial section like this, so you can find thalamus over here, like this is thalamus. Now moving forward, gateway to the cortex. Thalamus is the gateway to the cortex. All the sensory stimuli, all the sensations from throughout the body except for the sensation of smell, except for the olfactory sensation, all the sensations will relay in the thalamus and then go to the cortex. So it is the gateway to the cortex, major relay for all the ascending sensory information to the cortex except for the olfaction. Now these are different types of nuclei which are present in the thalamus. So first one is the ventro-posterior-lateral nucleus, ventro-posterior-medial nucleus. Then we have the lateral geniculate nucleus, the medial geniculate nucleus, and the ventral lateral nucleus. These are the important nuclei of the thalamus. Now let's talk about them one by one. Firstly, we are going to talk about the ventral posterior lateral nucleus. Input to the VPL nucleus is coming from the spinothalamic and the dorsal column medial lemniscus. Spinothalamic fibers are going to take the pain and temperature sensation, and the dorsal column medial lemniscus is taking the proprioception and vibration sensation. So the senses which are coming to the ventro-posterior lateral nucleus is the vibration and proprioception coming from the dorsal column medial lemniscus, and pressure as well. Pain, light touch, and temperature are coming from the spinothalamic tracts. Destination is the primary somatosensory cortex because these are the sensations, and sensations are supposed to ultimately reach the primary somatosensory cortex. Then we have the ventro-posterior medial nucleus. That is, input is trigeminal and gustatory pathway. Senses are face sensations and taste, and destination is the primary somatosensory cortex. So you can remember it by the mnemonic makeup goes on the face. So ventro-posterior medial nucleus is responsible for the face sensations, and that is the input is coming from the trigeminal and the gustatory pathway. Then we have the lateral geniculate nucleus, cranial nerve 2, optic chiasm and optic tract. There the input is the senses which are taken up by the lateral geniculate nucleus is vision. The destination is the calcarine sulcus, and lateral is for the light. Then medial geniculate nucleus, The input is coming from the superior olive and the inferior colliculus of the tectum. The input, that is the sensation that is taken up by them, is hearing, and auditory cortex of the temporal lobe. It is very high yield. So medial is for the music and lateral is for the light. So light is for the vision, and you must remember that the lateral geniculate nucleus is taking the visual sensations, while the medial geniculate nucleus is taking the musical sensations or hearing sensations. Then the ventral lateral nucleus, the input is coming from the basal ganglia and cerebellum. The senses, these are not basically senses. The ventral lateral nucleus is responsible for the relay station. Motor relay station. Then the destination is the motor cortex, or you may say the side. Okay, just don't confuse yourself. The destination is the motor cortex. Okay, then epithalamus. The pineal gland is also called as epithalamus. We'll keep this session till here, and we'll continue from the thalamic stroke in the next session. Until then, Allah Hafiz, fi amanillah, and take care.